Hello everyone. Today we are going to see the treatment of penile carcinoma. Okay, we can jump directly into the treatment in this video. Before going into the treatment of penile carcinoma, you want to know about the TNM staging. Okay, so when coming to the TNM staging, T1, T2, T3 and T4. So we need to know what is meant by this T1. Okay, in T1 it is subclassified into T1A and T1B. So before going into this, what is meant by this T1? It is subepithelial involvement. T1A is subepithelial involvement without lymphovascular invasion or perineural invasion, and T1B is with lymphovascular invasion or perineural invasion. This grading is also included in this T1A. So in T1A it will be grade 1 and grade 2. T1B it will be grade 3. Coming to the T2, T2 is when the cancer involves the corpus spongiosum. Okay. T3 it involves the corpus cavernosum. In T4 it involves the adjacent organs. What are the adjacent organs? These are the prostate, scrotum and pubic bones. Then we can see the nodal staging N1, N2 and N3. In nodal staging, it is subdivided into clinical nodal and pathological nodal staging. Okay, in nodal staging, the side and the fixity of the node is taken into consideration. Okay. So coming to N1, it will be ipsilateral and mobile. Clinically, N2 it will be bilateral and mobile. N3 it will be fixed or pelvic node. So coming to the pathological end classification, PN1, PN2, PN3. This is clinical. So C. So what is PN1? N0 is no lymph nodes. Okay. N1 it will be less than 2 lymph nodal involvement. N2 it will be more than 3 lymph node involvement. So PN3 it will be fixed. So that will be clinical. In pathological, there will be extranodal extension or pelvic nodes. Then coming to metastatic staging. So M0 no mets, M1 metastasis. Okay, now let us discuss about the stage dependent local treatment of penile carcinoma. Okay, this is the stage dependent local treatment, depends upon the T of the TNM staging. So we can subclassify the T of the TNM staging as TIS, TA, then T1, that is grade 1, and grade 2. This is T1A. Okay, then T1B, that is grade 3. Then T3. This also T1B, in this category we can add T2 also. Then T3, T3 with urethral involvement. Okay, then T4. This is the local treatment. We are seeing the local treatment. So for TAS, this is carcinoma in situ. Okay, that is erythroplasia of curate or Bowen's disease. When it occurs in glands, it is erythroplasia of curate, and when it occurs in shaft, it is the Bowen's disease. In TAS, what is the treatment options we are having? So we have the laser treatment options. Okay, the lasers which are used are NDYAG or KTP or CO2 lasers. Okay, then this 5-fluorouracil local application or imiquimod local application is there. These are immunomodulators. Imiquimod is the immunomodulator. So for TAS, this imiquimod is the treatment of choice. Remember that. So coming to TA, TA is non-invasive carcinoma. Non-invasive. Okay, that is verrucous carcinoma. Then we have discussed already the T1 subepithelial connective tissue involvement, and this T staging also includes grade 1 and grade 2, that is T1A. So what are the treatment options we are having here? So we have glands resurfacing procedures. Okay, in TAS also we can use this glands resurfacing procedures. So in TAS we have three modalities: laser, local application of immunomodulators, and glands resurfacing procedures. In TA and T1A, we have this glands resurfacing procedures, then wide local excision. If it is involving the glands, then we can also do glandsectomy with reconstruction. And the other treatment options are laser. The same lasers which was used above can be used here also. So coming to T1B, that is grade 3 of T1 and T2, we can do the same things, okay, like glandsectomy with reconstruction and wide local excision. And the other thing which you want to notice is that in these stages of CA, we can also use radiotherapy. Radiotherapy is used when the tumor is less than 4 centimeter. For more than 4 centimeter, surgery. You will do surgery. So here also, if the TA or the T1A is less than 4 centimeter, we can do radiotherapy. Okay. So coming to T3, T3 is corpus cavernosal involvement. Here also we can use glandsectomy with reconstruction. Sorry, glans is the extension of the corpus spongiosum. So here glandsectomy we cannot do. We can do only partial penectomy plus reconstruction, or if the tumor is a very small tumor like less than 4 centimeter, we can do radiotherapy. So T3 with urethral involvement. Okay, for this we can do either partial penectomy or total penectomy with perineal urethrostomy. T4, when it involves the adjacent organs, we will give neoadjuvant chemotherapy. Neoadjuvant chemotherapy followed by surgery. If it is responsive, we can do the surgery. And for recurrence groups, already we have done the surgery, but the tumor has recurred. In that kind of stages, CU or a recurrent CS. In that kind of stage, we can do salvage surgery. Okay, that means either partial penectomy or total penectomy. Now we will see the nodal treatment of penile carcinoma. Nodal treatment. Before going to the nodal treatment, we should know what are the low risk tumor and high risk tumor. So low risk tumors are TAS, TA, T1A, that is grade 1, grade 2. T1B tumors, that is grade 3, and T2 to T4. These are the high risk tumors. So let's see the nodal management for TIS tumor, that is carcinoma in situ. Assess the nodal status first. Palpation is enough. If the nodal status is negative, you observe. If the nodal status is positive, you go for antibiotic. The reason for antibiotic is that in TAS, the lymph nodal involvement is less than 5%. So it's unlikely to be a lymph nodal metastasis rather than a infection. So after giving antibiotics, you reassess the lymph nodes. So reassess. If the lymph nodes are negative, observation. If the lymph nodes are positive, go for fine needle aspiration cytology, FNAC. In FNAC, if it is negative, you observe. If it is positive, go for excisional biopsy. If the excisional biopsy is negative, then observation. If it is positive, do the lymph node dissection. So what lymph node dissection you will do? You will do a ipsilateral superficial lymph node dissection, that is lymph node dissection above the deep fascia. If you have a frozen section, if the lymph nodes are involved, more than 2 lymph nodes are involved, lymph nodal involvement, or if there is a extranodal extension, you go for pelvic lymph node dissection. Pelvic lymph node dissection, you will remove the external iliac, internal iliac, obturator, etc. Plus contralateral superficial lymph node dissection. Okay, this is the rough idea. For TAS, first you give antibiotics, then you do FNAC. If it is positive, do FNAC. Then if it is positive, do excisional biopsy. Now coming into the nodal treatment of TA, T1A, that is grade 1, grade 2. Okay, the same thing. Assess the nodal status. If it is positive, go for FNAC directly. You don't want to give antibiotics in this case, because the risk of nodal involvement in TA is around 10%, and for T1A it's around 20 to 40%. So that's the reason it's unlikely to be an infection. Mostly it will be a metastasis only if nodes are positive. Not mostly, it can be a metastasis. So if the FNAC is positive, go for excisional biopsy. If the extension biopsy is positive, you go for lymph node dissection same I have mentioned before. The same thing, that is ipsilateral superficial lymph node dissection, and if the nodes are involved more than 2, and if there is extranodal extension, you go for pelvic lymph node dissection and contralateral superficial lymph node dissection. The same thing as I have mentioned before. EUA guidelines states that for T1A grade 2 tumor also, we can go in for lymph node dissection rather than observation. Now we can see the management of high risk disease. So what are the high risk disease? T1B and T2 to T4. So we want to do the clinical examination of the lymph nodes. There may be 3 possibilities. The first possibility is that bilateral lymph nodes are negative. The second possibility is that unilateral lymph node is positive but it is less than 4 cm. The third option is that bilateral lymph nodes are positive but it is less than 4 cm. So first let's discuss this first scenario. Here the bilateral lymph nodes are negative but the disease is high risk T stage. So what we are going to do, since it's a high risk carcinoma, the chances of nodal metastasis is more than 50. So we are going to do the frozen section if it is available. If the frozen section is negative, we can observe. If the frozen section is positive, we will go for deep lymph node dissection, inguinal lymph node dissection and pelvic lymph node dissection. Okay, the criteria for doing this deep and pelvic lymph node dissection is that more than 2 lymph nodal involvement and extranodal extension if it is positive. And along with the deep inguinal lymph node dissection and pelvic lymph node dissection, we will also do contralateral superficial lymph node dissection. Okay, simple. Then coming to the second scenario. The unilateral lymph node is positive but is less than 4 cm. Okay, the reason for 4 cm cutoff is that for disease more than 4 cm, you will directly go for adjuvant chemotherapy. If it is less than 4 cm, you will go for surgery, that is lymph node dissection. So this is an unilateral disease. So for this, we can go for unilateral superficial and deep ilioinguinal node dissection plus pelvic lymph node dissection along with contralateral superficial lymph node dissection. Okay, simple. And coming to the third scenario, here bilateral lymph nodes are positive and it is less than 4 cm. So bilateral nodal involvement is very rare. For that we will do a FNAC. If the FNAC report comes out to be negative, we will follow the same thing, the same algorithm of a bilateral lymph node negative algorithm. Okay, if the FNAC is positive, there are 2 options we can do, option 1 and option 2. So what is the option 1? We can go directly for bilateral inguinal lymph node dissection followed by adjuvant chemo. Okay, and the option 2 is that we will give neoadjuvant chemo followed by lymph node dissection. Okay, so what are the indications for for adjuvant chemo. If there is a pelvic lymph node involvement, pelvic node involvement, if there is extranodal extension, if the lymph node is fixed, and if there are more than or equal to 3 lymph node positive, we can also give adjuvant chemo. And in this setting also, since we are doing pelvic lymph node resection, we can subject this patient, this category, the second option category patient, also to adjuvant chemotherapy. So let's consider the other advanced scenario, like if it is a fixed node more than 4 centimeters and the pelvic lymph node involvement. In this case, we will go for adjuvant chemo, neoadjuvant chemo. If there is response, we will do surgery, that means lymph node resection. If there is no response, the patient will enter a clinical trial, palliative chemo or chemoradiation. Okay, this is the management of the lymph nodal management of penile carcinoma. So in this video, we have seen the TNM classification, low risk and high risk patients, treatment options of low risk and high risk according to T stage. That is, we have seen the various modalities of therapies like laser therapy, gland resurfacing, wide local excision, and the topical application of imiquimod and 5-fluorouracil. And at last, we have seen the lymph nodal management of high risk and low risk patients, and at last advanced disease lymph node management. I hope you understand this video. Kindly support me. Thank you.